will be starting the lecture. I'm requesting everyone to have all your videos on. Let's see if the bandwidth can handle all the videos to be on. Okay. Hi. Excuse me. Can you be see? Are you seeing the slides? Are you seeing the slides? Okay. Can you hear me? Can you hear me? Okay. So today we will be talking about somatic symptom and related disorders. And these are the objectives. After completing this period of instruction, everyone is hopefully in a position to render an accurate diagnosis when presented with symptoms characteristic of somatic symptom and related disorders, and identify the different somatic symptom and related disorders, know about the epidemiology, etiology, clinical features, course and prognosis, and treatment of the conditions. Okay, and lastly, you are to differentiate somatic symptom disorders from fractious and malingering. Okay. Today, when we say someone is hysterical, what do we actually mean? Can I hear from you? If you hear the word hysterical, what comes to mind? A volunteer, please. What comes to mind when you hear this word hysterical?
Doc,
Hello? Yes. Yes.
unorganized thoughts po.
Sorry, you said disorganized thoughts. Yes, did I hear that right? You said disorganized thoughts.
Yes po.
Okay. All right. Any other understanding of the word hysterical? Could there be a reason how come this picture portrays images of women? Okay. Other synonyms for the word hysterical. Can I hear from one person more? I'm going to ask someone I see on my screen, okay? Miss Pauline Quanico, maybe a synonym that you can think of for the word hysterical.
Unrestrained po.
Unrestrained. So could be frantic, or out of control. Thank you, Pauline and Kyle. The antonym of hysteria being all of these words: calm, collected, peaceful, and the rest. Okay. Going back to the note of the prior image of only women, did you know that this word hysteria is derived from the Greek word hystera, which means uterus? Back in the ancient times, hysteria was used to describe a group of disorders that affected women, in whom symptoms were believed to be the result of suffocation of the mother. It was believed that a uterus could migrate around the female body, causing many number of ill effects. The premise was that if the patient had no frequent sexual intercourse, the uterus will be frustrated by lack of proper use, leave its anatomical position, and move around the body, causing the symptoms. Hippocrates himself described hysteria as occurring in either widows or virgins, resulting from the neurotoxic effects of the frustrated uterus. Thus came about practices like here as depicted from ancient Egypt, when the womb wandered toward the head, noxious smelling substances were burned near the nose to repel the uterus. so that it is forced to go back to its original anatomical position. Those were back then. But it was in the 18th century that a move from the idea of hysteria being caused by the uterus to it being caused by the brain, it came to be then that it was considered a physical ailment. Sorry. First described medically by Jean-Martin Charcot in 1880s. Hysterics presented losses of sensation, not responding to pinpricks, blindness, difficulty walking, and even paralysis that had unexplainable symptoms. Okay? Charcot came to the conclusion that these disorders had a psychological cause, and that led to use of hypnosis to eliminate the symptoms. We see here John Martin Charcot this demonstrating hypnosis in a hysterical patient to his students. Charcot directly influenced Freud, who became more interested in the emotional problems of his patients, thus bringing back the psyche and the soma. The disorders we will review today will bring exactly the psyche, brain, mind, and the body all together. These medical conditions were called somatoform disorders in DSM-4. Back then, the focus was on the somatic symptoms that are medically unexplained, like insomatization disorder, pain disorder, hypochondriasis, conversion disorder, and body dysmorphic disorder. Note that in DSM-5, body dysmorphic disorder is now under obsessive compulsive and related disorders. Further, in DSM-5, the somatic symptom disorders have been reconceptualized. The focus has been directed from focus on somatic symptoms to the patient's excessive thoughts, feelings, and behaviors that arise in response to his or her somatic symptoms. How will somatic symptom disorder look like in a patient? Those individuals who report troublesome medical symptoms, who frequently visit doctors, take unnecessary medications, undergo needless medical procedures, and tend to baffle and frustrate clinicians because medical symptoms defy medical investigation. It is challenging for clinicians because they must balance their concern to investigate the patient's complaints against the real concern of inadvertently encouraging help-seeking behavior and through unneeded medical procedures. There are 7 somatic symptom disorders that are listed in DSM-5. They include somatic symptom disorder, illness anxiety disorder, conversion disorder, or now is called functional neurologic symptom disorder, psychological factors affecting other medical conditions, factitious disorder. And 2 residual categories, other specified somatic symptom and related disorders, and unspecified somatic symptom and related disorders. These can be used to diagnose patients whose somatic symptoms do not meet the criteria for one of the more specific disorders. Someone please be helping read through the DSM-5 criteria for somatic symptom disorder. Okay. I'll be asking a volunteer to read criteria A to C. Okay. I'll be calling someone next that I see on screen, okay? Miss Alia Joy Tolentino, can you please be helping read the criteria?
For the criteria A po, greater than 1 somatic distressing symptoms. Then
Mhm.
for criteria B, disproportionate and persistent symptom-related thoughts. Then criteria B2, persistent high level of health and symptom-related anxiety.
Mhm.
Criteria B3, excessive time, energy spent on symptoms and health.
Mhm.
Then criteria C is duration of greater than 6 months.
Okay. Thank you very much. I'll be asking Mr. Enrico Asuncion to read the symptoms for B1. These are the symptoms we'll hear from the patients. Mr. Asuncion?
For symptoms B1,
Hmm.
this will never end. I cannot trust my body anymore. And then next is, how can I continue living with this burden? Then I know that my doctor says that everything is all right with me, but what if he has overlooked something?
Hmm.
Then next is, there has to be a reason for my symptoms. I need to find a doctor who can help me. And then this pain is ruining my quality of life. How much longer can I bear it?
Okay. Thank you very much. Or for symptoms B2, I'm going to ask Miss Dana Cabral.
For symptoms B2, the patient experiences anxiety, hopelessness, and despair, and anxiety that doctors have overlooked as severe cardiac disorder.
Okay. For B3, I'm going to ask Mr. Philip Cardenas.
For B3 po, excessive
Hmm.
time and energy spent on symptoms. So the following illness behavior cost the patient a lot of time. Every time pain intensifies, patient looks for a calm place, rest, and focuses his attention on his body, measures blood pressure and heart rate several times a day,
Hmm.
several medical consultations every month, and ruminations about symptoms, distractions, and concentration deficits.
Okay. Thank you very much. Let's watch this video together. Okay.
Deborah is a 44-year-old woman who has visited the doctor multiple times, and none of them have been able to diagnose her. Hello, everyone. This is Dr. Jones, presents with ankle pain. Today in the psychiatry series, we're going to be discussing blood vision, bloating, chest tightness. In this lecture, we'll discuss the aching in the legs and approaches.
Okay. Bakit nag-overlap yun?
So, somatic symptom disorder. Well,
Okay. So that actually, that patient, sorry. Okay. Hold on.
hello, everyone. This is Dr. Jones from drbean.com. Today in the psychiatry series, we're going to be discussing somatoform and related disorders. In this lecture, we'll discuss the presentation and treatment approaches to such disorders. So let's look at the first case. Deborah is a 44-year-old woman who has visited the doctor multiple times, and none of them have been able to diagnose her condition. Today, she presents with ankle pain, chest pain, back pain, headaches, blurred vision, bloating, chest tightness, tingling in her fingers, aching in her legs, and ear pain. Does anyone know what the diagnosis is? Well, this case illustrates somatic.
Oh, so that patient actually had somatic symptom disorder. Okay. Now, let's understand somatic symptom disorder from a psychodynamic lens. Okay. That somatic symptoms present as a response against unconscious emotional issues. Two factors initiate and maintain somatic symptoms: primary gain and secondary gain. What does primary gain mean? It keeps internal conflicts outside the patient's awareness. So that is a primary gain. Hence, the symptoms provide protection from anxiety or symptoms to emerge from the consciousness. The secondary gain are the tangible advantages and benefits as a result of being sick, like being excused from obligations and difficult life situations, receiving support and assistance that might not otherwise be forthcoming. So, receiving attention and sympathy, like from missed work. How about cognitive theories? You're familiar with this. Cognitive theorists believe that somatic disorder are a result of negative beliefs or exaggerated fears of physiological sensations. Individuals with somatic-related disorders may have a heightened sensitivity to bodily sensations. This sensitivity, combined with their maladaptive thought patterns, may lead individuals to overanalyze and interpret their physiological symptoms in a negative light. Okay. For example, an individual with headache may catastrophize the symptoms and believe that their headache is a direct result of a brain tumor, as opposed to stress or other inoculate reasons. When their medical provider does not confirm this diagnosis, the individual may then catastrophize even further, believing that they have an extremely rare disorder that requires an evaluation from a specialist. Now, looking at somatic symptom disorder from the social learning theory. And I hope you learned about this in your lecture about theories on personality. Do you remember Albert Bandura? Can I see nods there? If you remember Albert Bandura, he is a principal founder of social learning theory that says individuals learn new ways of thinking and or behaving not by direct experience, but by observing how others think and behave. Symptoms that are learned from family members may model maladaptive illness behaviors and ways of coping. Therefore, if, for example, a child observes her parent experiencing frequent headaches and receiving attention for those pains, she may consequently imitate that behavior and learn that headaches lead to positive attention. As the child ages, experiencing somatic symptoms may become the primary coping strategy used when under stress. Okay. Children may also learn to view certain symptoms are more serious than others depending on how their parents react to them. So they may witness a close family member experience a serious illness such as cancer, which can produce pain, nausea, vomit, fatigue, among other symptoms. The child may learn to believe that the symptoms themselves are distressing and life-threatening rather than the cancer that caused them. Next is illness anxiety disorder, a new diagnosis in DSM-5 used in patients who are preoccupied with the possibility of having or acquiring a serious illness. The person may amplify normal physiological sensations and misinterpret them as signs of disease. Yet the distress comes mainly from his or her anxiety regarding the meaning, the significance, or cause of the symptoms, and not the symptoms themselves. Under DSM-5 or 4, some of these individuals would have been diagnosed with hypochondriasis, which involves a belief that one had a serious disease, despite reassurance that one did not. There are those who would frequently use medical care and therefore are called care-seeking, and those who rarely go to the physician or for tests and are called care-avoidant. People with illness anxiety disorder are typically hypervigilant about their health. Sorry. They monitor their body, seeking evidence of disease while exaggerating the importance of every ache, pain, discoloration, bowel change, or noise. They engage in significant checking behaviors to ensure that there are no lumps or swellings, and are often addicted to internet searches. Again, those who are easily alarmed about health, those that tend to not be assured by negative tests or a benign course, those preoccupied with the idea of having a serious illness that directs attention from other activities, those whose incessant worry become frustrating to family members and may lead to considerable strain within marriages and families. Okay. Physicians find these patients frustrating and difficult and are often dismissed as chronic complainers. Patients, on the other hand, feel ignored or rejected by physicians or are made to feel ashamed by those who tell them that their complaints are not legitimate. It's all in their heads. Like patients with somatic symptom disorder, people with this condition sometimes doctor shop and receive unnecessary evaluation, tests, or surgeries. And they're also at risk for alcohol or drug addiction. Okay.
Lali is an 18-year-old singer, and she presents to the doctor convinced she has bladder cancer. She reports constant abdominal pain that doesn't go away. She has seen doctors numerous times, and she's just told there's nothing wrong with her. She doesn't believe them, but she thinks that you can help her because she knows 100% there's something wrong with her. Do you know what diagnosis it is?
So what does that patient have? Raise of hand, please, or maybe type in the chat box. That patient has. Are you there? Are you there? Are you with me? What does this patient have? Videos on, please. That patient has, and it was previously discussed, illness anxiety disorder. Okay. Now, on to functional neurological disorder, or known before as conversion disorder. These involve symptoms that often conform to a patient's concept of disease rather than to a recognized physiological pattern. For example, symptoms of anesthesia may follow a stocking and glove pattern, not a dermatomal distribution. Often, the illness is preceded by conflicts or other stressors and may seem to be associated with apparent psychological factors. How come it has been called previously as conversion? Because emotional pain or other affect states are converted into physical symptoms, and focusing one's attention on somatic, bodily, rather than intrapsychic concerns. A conversion reaction can be rather acute, like a temporary loss or alteration in motor or sensory function, such that it would be impossible for the patient's presentation to be consistent with a neurologic condition. Patients sometimes present with symptoms based on their prior experience with an illness or based on illness symptoms modeled by an important person in their life. They may unconsciously model the symptoms on those of someone important to them. For example, a parent or a person who has recently died may serve as a model for conversion disorder. In this process, you know from defense mechanisms, is called identification. Moreover, symptoms cannot be explained, again, neurologically. So think of a conversion disorder for patients with sudden and temporary paralysis, abnormal movements, or being mute, blind, and deaf. For paralysis, when the examiner drops a paralyzed hand onto the face, the hand falls next to the face and not on it. In conversion disorder blindness, for example, patients walk around without collisions or self-injury. Their pupils react to light, and their cortical evoked potentials are normal. Patients may also present with pseudo seizures, or now what is more appropriately called non-epileptic seizures. These are spells that resemble true seizures, but are not accompanied by abnormal brain waves. Although please note that pseudo seizures may also occur in patients with genuine epileptic seizures. The phenomenon of labile indifference, or inappropriately cavalier attitude toward severe symptoms. That is, patient seems to be unconcerned about what happens to a significant impairment. This has been associated with functional neurologic symptom disorder, but it is not diagnostic nor pathognomonic of conversion disorder. Take a look at this table from Synopsis of Psychiatry by Kaplan, which shows distinctive physical examination findings in conversion disorder. And please get to know the terms astasia, abasia, and Hoover test. Jacques Bloch introduced in 1860 the term astasia abasia, which means inability to stand and walk. And he included paralysis, jumping, fits, tremors, and bizarre behavior as part of this syndrome. This is the paradoxical ability to use the legs normally, except when standing or walking. And Hoover test is as what you will read in the table. There is spontaneous remission for acute conversion symptoms. It is high, so that even without any specific intervention, most patients will improve and probably not suffer any serious complications. Okay. Most important in conversion or functional neurologic symptom disorder is a relationship with a caring and confident therapist who focus on issues of stress and coping. Now, we together watch this video and I'll ask you a question after this. Please watch intently.
Jen is a 25-year-old female and she presents to the clinic unable to move her upper arm and her lower legs. A full workup is done, no abnormalities are seen. However, when further questioned, she reports an argument with physical violence involving her girlfriend that occurred this morning. And since this morning is when she hasn't been able to move her upper arm and lower legs. Does anyone know what diagnosis this is?
What is the diagnosis for that particular patient? You can be typing in the chat box. What is the diagnosis for that particular patient? I see Mr. Acuna about to type in the chat box. What is the diagnosis for the patient?
I'm thinking of conversion disorder po.
Yeah, it's conversion disorder, or from DSM-5, we call it now functional neurological symptom disorder. Thank you, Mr. Acuna. Now, proceeding to psychological factors affecting other medical conditions wherein there is a presence of one or more clinically significant psychological or behavioral factors that adversely affect a medical condition by increasing the risk for suffering, death, or disability. The psychological or behavioral factors include psychological distress, patterns of interpersonal interaction, coping styles, and maladaptive health behaviors. Okay. In this condition, to simplify, there is an existing medical condition involving any of the organ systems. And there is the psychological or behavioral factors that adversely affect the medical condition. There must be a clear-cut temporal relationship between these factors and the development of exacerbation and recovery from the medical condition. So think of psychological factors affecting other medical condition as a diagnosis in a need for acute chest pain, for a patient with diabetes who manipulates insulin administration in order to weight. Consider their medical conditions. Two categories: related disorder and unspecified. These can be patients whose somatic criteria for yes, is one that you learned from OB. That is a false belief that one is pregnant with objective signs and reported symptoms of pregnancy. Okay. as a review, somatic with of functional neurologic disorder. And if the person is preoccupied with the idea of being disorder, the mechanism by which the symptoms of these cited conditions are produced all reside in the unconscious. Okay? All reside in the unconscious. You've learned about the unconscious in one of your first lectures in second year. Condition are well aware of disorder patient on being the mechanism I lost internet connectivity. Can you hear me now? Hello, can you hear me now?
Yes, po, Doc.
Hold on. What did you last hear me say? What did you last hear me say?
Yung sa may unconscious po.
Okay. There you go. So how to differentiate factitious versus malingering? For factitious disorder, where illness or symptoms are consciously produced, but the motivation behind producing the symptoms reside in the unconscious, okay? Whereas in malingering, both the mechanism and motivation for illness production are all conscious, okay? In factitious disorder, there's intentional production or feigning of physical or psychological signs or symptoms. Patients with this disorder have no obvious external incentive for the behavior, such as economic gains, but instead, these individuals are thought to be motivated to be in the sick role, receive medical care, and partake of the medical system. Okay? Patients can use strategies to fake illness, such as report symptoms suggesting an illness without having them, produce false evidence of an illness, and intentionally produce symptoms of illness. Okay? Some factitious disorder appear to make hospitalization a way of life and have been called hospital hobos or peregrinating problem patients, or patients termed to have hospital addiction, polysurgical addiction, or gridiron or washboard abdomen. Professional patients. The term Munchausen syndrome also has been used to describe patients who move from hospital various. The name comes from the fictitious known for his tall tales and fanciful exaggeration. Okay. These are the psychological factors, I'm going to leave it to you to be reading how we come to understand psychologically factitious disorder. Okay? This is in the interest of time. Okay. All right. Now, factitious disorder, we see this in forms of pseudologica fantastica. There's limited factual material mixed with extensive and colorful fantasies. The listener's interest pleases the patient and reinforces the symptoms. Okay. It could also be seen in impostorship, okay, where this is a different connotation from maybe what you know of imposter syndrome. One assumes identity of a prestigious person, like men report being war heroes and show scar due to dramatic exploits. They may say they have ties to accomplished or renowned figures. These are examples of factitious disorders. Okay. There is also what we call factitious disorder imposed on another. Okay, like the one previously heard earlier. The person intentionally produces physical signs or symptoms in another person who is under the person's care. So most common case will be a mother who deceives the medical personnel into believing that the child is ill. We can look at disorders that we have discussed as a continuum, from somatic symptom disorders that are unconscious and non-volitional to conscious and willful condition called malingering. Malingering is included here because it is important as a differential considerations for these conditions. In DSM-5, it is included in the category other conditions that may be a focus of clinical attention that are not considered attributable to a mental disorder. That's why it is part or Z code diagnosis. Okay, now a bit about malingering. Again, there's intentional production of false or grossly exaggerated physical or psychological symptoms, all motivated by an external incentive. Like they will avoid work or military duties or avoid or obtain financial compensation, or they can avoid criminal prosecution, obtain drugs, or they secure better conditions. Okay. Mostly obvious reasons to feign illness, prisoners, factory workers, or persons living in unpleasant situations, such as homeless persons. The illness may provide an escape from a harsh reality, while hospitals may offer a temporary sanctuary. Again, there is a medical legal context of the presentation. Okay, person is being referred by his or her attorney for examination. There's marked discrepancy between the person's claimed disability and objective finding, and there's lack of cooperation during diagnostic evaluation and non-compliance with treatment regimen. There may be the presence of an antisocial personality disorder. Okay. Given the challenges posed in dealing with these patients, it might be tricky, and one can easily trap of doing harm. But please remember the Hippocratic oath you will take as future doctors to do no harm. Here are what should be avoided and recommended communication strategies from the Royal College of Practitioners for patients with somatic symptom or related disorder that I will leave for you to read on your own. As we wind down, may I ask a volunteer to read on the last 6 clinical points to remember for this lecture. And the volunteers, no longer forced volunteers, each will be given a copy of a free ebook I will send into your email. So volunteer number 1 to please read statement number 1. Volunteer, please. Number 1. Yes, go ahead. Sorry, I can't see you on the screen. Go ahead.
So the physician should invalidate the patient's suffering and acknowledge his or her symptoms.
Okay, thank you, Paolo Pampros. Group leader, kindly note of those who are volunteering to read, okay? All right, next, please. Next, please.
Doc,
Yeah, go ahead. Thank you, Angelo.
an
Go ahead.
empathic relationship should be established to reduce the patient's tendency to doctor shop. So the primary physician should preferably become the patient's only physician.
Okay, thank you. Number 3. Volunteer number 3. I'll wait for you, volunteer number 3.
Doc, for number 3.
Thank you, Ken.
Okay, for number 3, patients benefit from brief scheduled visits. So as the patient improves, the time between visits can be extended.
Okay, thank you. Number 4, please. Wait for volunteer number 4.
Doc, ako na po si number 4.
Okay, thank you. Go ahead.
So for number 4, the physician's goal is not to remove symptoms but to improve function and quality of life.
Thank you, Dan Ira King. Volunteer number 5.
Good morning po, Doc. I'll do number 5.
Thank you.
So the use of psychotropic drugs should be minimized. No medication has proven value in somatic symptom disorder. Illness anxiety disorder may respond to selective serotonin reuptake inhibitors, and psychotropic drugs with abuse potential, such as benzodiazepines and opioids, should be avoided.
Okay, thank you very much, Micaela Kasinghal. And lastly, volunteer number 6.
Ako na lang po, Doc. For number 6, medical evaluations should be minimized to reduce expense and iatrogenic complications. Conservative management has been shown to reduce healthcare costs.
Okay. Thank you all for volunteering to read clinical points. When you become future doctors and when you encounter these patients, please remember these 6 points. This is a cartoon that's meant to be funny. Is it funny? It is meant to be funny, right? But for patients, it may not be. Future doctors, if there are patients like the ones we have discussed earlier that come to your clinics, please do not try to talk patients out of their symptoms or tell them it is all in their head. Yes, it is in their brain. And given what you've learned today, their symptoms are real and distressing. Be the ears that listen and hands that heal. Thank you all for listening. These are the references for this lecture. Okay, we're ending the lecture 5 minutes early. I believe the PDF file of the lecture has already been uploaded. If not, then do please let us know. Okay? So, any other questions before we say goodbye? Concerns, questions? None? So, if there are none, I note that, yes, a volunteer. Please be typing in the chat box the names of all the volunteers, so that I can send you a free ebook. Okay? Or get in touch with the department secretary so that I am able to share the free book. Okay? Thank you all, and have a good lunch. Have a good week. Bye.
Thank you,
Thank
Doc.
you po, Doc.
Thank you po, Doc.
Good.